You just came from the gym, Rosa. Well, John's wife, Laura, says I normally look like I've come
Not
in
normally, just on the podcast.
well, that's what I normally dress like, though, John.
That's normally. She just.
So Preston thinks that dressing up is just a New Year's resolution, when in fact I'm leaving the COVID era behind, Rosa.
It took a few years.
What do you think, John? What's the chances of this holding up?
I think it's good. This was your look for the longest time. I think it looks really sharp. It looks great. I'm sick with it. Going.
It sounds like water is pouring into the podcast, John.
It does.
Do we have a leak? And John, we do have news. Rosa is my fiance. What do you know?
I think that's fantastic, and it doesn't surprise me. It's
Congrats.
a long time coming.
Oh, thank
Of you.
you.
It's like a ventriloquist act. I'm moving my lips, and Rosa is speaking for me. A long time coming.
The first time, Rosa, that I was wondering what to do on the weekend, I called John, and John said, "You should get engaged."
Yeah,
That was what it
Yeah.
Yeah.
As
his words.
soon as he met you, that's the woman.
Well, but we're here with Preston to kick off the year. So, John, maybe we should get to the 988 Lifelines podcast.
I think we should.
All right.
Let's do it.
Welcome aboard Lifelines with David and John, your guide to charting the transformative course of crisis intervention and the game-changing 988 Lifeline.
Well, welcome back and Happy New Year. 35 episodes of season 1. John, it was a pleasure. Brooklyn, my friend.
It was fantastic. This
Kristen,
year it's going to be even better, Dave.
I think so. I have a good feeling about it. Kristen and Karen were terrific last year in setting up our first season of the Lifelines podcast. I went back and watched an episode of Preston, our guest today, on Travis Atkinson podcast. I didn't realize he'd been doing a crisis podcast since 2020, John, maybe even a year before that.
Wow.
So we've gotten carried away with the wave. Jason and Travis Kelsey inspired everybody. If those two guys can do a podcast, then
we can. Absolutely.
That was one of my favorite memories of 24. Brian Mashara says, everybody's doing a podcast now.
Well,
but he was on our program. He was great.
Yeah, and he seemed to do it so happily after complaining.
But we're going to do it again this year, John. We're going to go to the vault, visit the history, but more importantly, we're going to talk about where we're at and where we're going and the vision of crisis care that feels like care to everyone, available to people in need. And we're going to do that with the nation's best, people like our guest today. So, John, tell us about Preston Looper, Full Tilt Strategies, and the work that our amazing kickoff for 2025 will bring us.
Well, David, I am so delighted to have our friend Preston with us today. Preston Looper is the CEO, founder. He's the guy at Full Tilt Strategies. He provides consultation on the full spectrum of crisis care, whether it's helping public or private health systems leaders build better crisis hotlines, mobile crisis services, co-response, or jail diversion services. And prior to starting up Full Tilt Strategies in 2020, Preston led crisis-oriented clinical innovations projects at Harris Logic and ADAPT Community Solutions in the Dallas-Fort Worth area for about a dozen years, including overseeing an AAS-accredited call center and mobile crisis services in the metropolitan area, as well as leading nationally recognized jail diversion and care coordination projects for persons with mental illness caught in the correction systems. Preston, you got to correct me if I was wrong about any of that.
No, beautiful. Thank you so much.
Oh, now you've been a clinician for over 30 years. Is that right?
Yeah. I came up as a mental health clinician.
Yeah.
Grinding away in the public sector. And as you know, if you're in the public sector, you're providing crisis care.
Amen to that. And you've been doing an amazing job, both consulting and overseeing clinical care for so long. And we're so glad to have you with us today.
Thanks.
For a podcast of 2025.
Yes. Thanks for letting me kick off 2025.
So, Preston, you were crisis when crisis wasn't cool, and it's the hottest thing on the block right now. But before we jump into that, We want to get to know you a little bit, and we're going to start with a segment. Last year we did the Superfan, John. This year's first segment is actually going to launch out with Don't Mess with Texas.
She's
So,
going to be for us, Preston.
Preston, I've got a trivia, set of 10 trivia questions.
Wow.
And I'm going to pose them all to Dr. John Draper. Now, John has a leg up on the normal.
I do.
Because my partner, Brooklyn, actually grew up in Texas.
I did.
Yeah. Outside Austin, John?
Austin and Houston primarily, but, arguably some people say those aren't really even Texas cities.
So, Preston, here's the over-under to start. I'm going to ask 10 trivia questions to John. How many they're just true false. How many is he going to get right? So you pick the over-under on this.
No, I think he's going to get 8. And the under he'll get at least 4.
Oh,
okay. I like it. Now we're going to ask him, Preston, if he's wrong on one of them, you let us know. Okay.
Right on.
All right, here we go. Number 1, John. Everything's bigger in Texas. It's the unofficial slogan. Number 1, Texas is home to the most valuable sports team on the planet. And that includes F1 and soccer and all that kind of stuff.
Yeah, I'm afraid it's the Dallas Cowboys.
It is for the 9th year in a row, Preston. I got too excited to give you a chance to.
And David's a Dallas Cowboy fan, by the way.
There's not much for Dallas to be rooting for, except that we, as of December 31st, somehow are the most valuable sports team in the world at $10.1 billion. Preston, any idea who might be number 2?
I would say San Fran, but it's probably not.
I can't remember. I think it might be the Golden State Warriors.
Oh, really?
Oh, okay.
After the run of, all right, John, you're 1 for 1. Number 2, there are 3 electric grids in the U.S., and one of them is Texas. Texas.
Yeah, 100%. Yeah, and they're still married to that thing. They're the most It's proof of how knuckleheaded state government is in Texas.
What is the history of that, Preston? Do you know?
I don't know, but there's a gosh darn independent thing where we wouldn't want to collaborate with, different municipalities, certainly other states, because they might mess it up.
Gosh darn independent thing. Is the talk of secession still come up from time to time?
Every year, every day.
All right, John, third question. George Bush once said, "Some folks look at me and see a certain swagger, but in Texas, we just call that walking."
That has got to be true.
Of course.
That to be true. Yes.
3 for 3.
Yeah.
I'm from Tennessee, Preston. It's a long state. Takes 7 to 8 hours to drive from one end to the other. But the longest road in Texas is over twice that long. True or false, John?
I'm sorry. How many hours?
So it's 7 to 8 hours to drive from Bristol to Memphis, Tennessee. It's
Oh, yeah.
440 miles long.
I know it's at least 13 hours. So I'm saying yes to that.
What do you think, Preston?
I'm thinking maybe so. The one that I know is El Paso's closer to LA than Texarkana. So there you go.
That's crazy. It's true. U.S. Route 83 is nearly 900 miles long.
Wow.
Highest population of cattle in the U.S. is in Texas. True or false, John?
False.
Preston?
False.
It's true. There are 12 million cattle, according to the latest survey, nearly as many as Nebraska and Kansas combined.
So
Wow.
that means there's a whole lot more bullshit in Texas.
Yeah.
First swear word of the 25 podcast.
It's early, David. Here we go.
Don't mess with Texas was originally an anti-littering campaign slogan.
Damn right it was. Yes. Yep.
Preston?
True.
Yep.
Yep.
The King Ranch in Texas is larger than a state.
Oh, meaning Rhode Island? Yes. Yes.
Larger than Rhode Island at 825,000 acres. All right, John, you've just missed one so far. If Texas were a country, number 8, its economy would rank in the top 10, just ahead of Russia and Canada. True or false?
I'm going to say true.
Preston?
True.
Texas economy is 2.5 trillion with a T, just only behind California.
California, I knew was in there.
Number 9, it's been dubbed the Beyonce Bowl, and her halftime tribute to Cowboy Carter was all things Texas. It had more live viewers than the two NFL games on Christmas. True or false?
It had more live viewers than the 2 NFL games on Christmas?
Correct.
It was on Christmas, wasn't it?
The halftime show itself, though.
The halftime show was on Christmas Day, wasn't it?
Versus the games.
What, you mean people tuned out? That doesn't count? That's why they had her for halftime, so people could come watch the game. They said, I'm just watching.
The highest number who were in the game at any point versus how many watched that halftime show.
Oh. Well, more people were watching during that halftime show, including my dog. Yeah, that's true.
The halftime show is also now available on Netflix by itself. And it's estimated
It was really good. It was really good.
Okay, last one, John. And you're flirting with the 8. You get this one right, and you hit you'll actually exceed Preston's upper end. Texas is the only state that can fly its flag at the same height as the U.S. flag.
They're not allowed to do that, no. But they're gonna break the law and do that. Absolutely. You know, in Austin, the Capitol, they said they weren't allowed to build the Capitol as high as the U.S. Capitol, so they did it 1 foot shorter.
Preston, John says they cannot fly the flag as the same height as the U.S. flag. What's your thought on that?
I don't know about can. I'll say shouldn't.
That's the right one.
So apparently there's an urban legend that Texas is the only state that can fly its flag at the same level. The truth is every state can fly its flag at the same level, John.
Oh.
Okay.
So, but Texas was an independent republic in the 1800s.
It was indeed.
So, Preston, were you born in Texas or did you make it home later on?
You know, I was born in Southwest Oklahoma, and after I got out of university, this was, the economy was tough, and all the jobs were in the Dallas-Fort Worth area. So followed a lot of friends to this area, and so started here.
And David, just one more piece of trivia. And Preston, I'm sure you went to elementary school in Texas, did you?
No, in Oklahoma.
Okay, Oklahoma. Yeah. Well, so in Texas, in elementary school, maybe as long as I think it's just elementary school, we not only started the day with Pledge Allegiance to the flag of the United States, but also a Pledge Allegiance to the Texas flag.
No, you did not, John.
We did.
How does it
my
go?
goodness.
I want to hear it.
I have a block.
You have a block.
I mouthed the words to that every time. They couldn't tell whether or not I was actually saying anything.
Preston, is this this sounds like another urban legend. Can you speak to that?
Well, I can speak to it. And, my kids were elementary school age when we returned to Dallas-Fort Worth from the Colorado area. And they had to learn the Texas Pledge of Allegiance every morning.
Well, that brings us to the point of the episode where we talk about our sponsor, John, and a pledge of allegiance to the Behavioral Health Link crisis software platform.
Yeah.
Which brings us this episode today with Preston. John, tell us a little bit about the 988 platform.
Yeah, and I know our guest today is very much in support of the kind of work we're doing because Preston's got the same interest we have in promoting innovative technologies that improve mobile crisis and other services. And Preston also shares our experience as a clinician who's dedicated to best practices in crisis care. Behavioral Health Link's GPS-enabled mobile crisis response dispatch software assures that the nearest mobile workers can respond to people in need, no matter where they live. The module's features are also for assessment information from the hotline call to be available Also allow the assessment information from the hotline call to be available to responders, in addition to safety information and alert features to protect workers from going into unsafe situations. Because BHL is the only crisis software developer that operates mobile crisis teams, we know how to develop technologies for teams that help them be more efficient, consistent, and aligned with promising practices. To learn more about our cutting-edge technologies, just check us out at behavioralhealthlink.com. David?
Thanks so much, John. Preston, we actually got an outreach from a private equity firm who was interested in this space, and they provided us this spreadsheet that they had done after some 60 customer interviews, and they hit up some of the other products in the field, and their conclusion was that Behavioral Health Link had the market leader in that space. We've been doing it a long time, John, and thrilled to have you on.
It's better every year, David, really.
Well, I appreciate it.
Congrats. Very cool.
Thank you. John, you've been on the team how long now?
It's been a little over 2 years, David.
Yeah, and Dr. Chuck joining as CEO and president this past year.
My crew.
Really excited about the work, the Georgia-based work that Atlanta, and of course, last year, John, my longtime business partner and the founder, Greg Graham, passed away, and now working closely with his widow, Harriet. So looking forward to this year.
Yes.
But John, that gets us to the sort of, as we go back to the beginning.
Well, we should go back to the beginning with you, Preston. I'm curious about your beginnings. I mean, you don't just get beamed into crisis care, most of the time anyway. I wondered how you first made the decision to get into mental health care from whatever you were doing, and then found your way into crisis care and developed your love for it.
Good point. I'll try to be quick about it. When I was in university, I took the second human anatomy and physiology course, and there, a lot on the brain and the nervous system. And I geeked out and ended up taking an abnormal psych course just to test the waters and see. And I fell in love and did a change from had a biology, chemistry, was thinking about pre-med, that sort of stuff, and made a switch to psychology, and the science of such was a good fit for how my brain worked. And, my internship post-master's was at the state hospital in Norman, Oklahoma, Central State Hospital. And I was hooked to the hip with a beloved mentor, a psychologist. And we evaluated every person that came on to that unit during a 9-month period. And so it was the essence of crisis care. So way back in the day, all the people brought in on involuntary holds, we evaluated them and made next steps. And then, went to Oklahoma and went to Texas and, did a couple of things and worked at a community mental health center and, ended up running the mobile crisis way back in the day. This is I did my master's treatise on an IBM Selectric. And then kind of like y'all, ended up, being a clinical lead for a tech company. Began crisis care work. Literally responding solo to sketchy situations with the pager and, payphone at the 7-Eleven. That's how I began. And, just the trajectory continued to follow and, just kept plugging away and eventually, discovered I knew a little something. And I was always been interested in how things work, almost kind of from an engineering perspective, and, found myself tinkering and trying to figure out how to build things that work in crisis care system, in particular, the interaction with the public sector safety net, 911, law enforcement, fire, EMS, the community mental health system, hospitals, all of that. So that was my history. And then, we went in 99 went to Central Colorado, and, ran a community mental health center up there as a clinical administrator, continuing to do services, and, did that for a little over a decade, and maxed out before I had enough chops to work virtually, and it wasn't happening. So began looking for a return to an urban area. I've got, country soul, but big city skill sets, if you will. And so had an opportunity in Dallas to build a crisis hotline and the related tech and jail diversion solutions kind of from the ground up. So interestingly, David, very similar to you in terms of, had a tech company, and it is a big deal. Wasn't able to get it across the line, but I think, talent and knowing how things work in a tech company is a superpower for you guys. And I'm, very, very cool to watch y'all do your thing.
Well, Preston, that's so kind of you. And look, we had the good fortune to be in such an innovative state as Georgia, and also to have the influences of Hurricane Katrina, John, and some of that background. Preston, you referenced the pager. And oh my God, John, you carried a pager, I'm assuming.
I did.
I almost go in a little bit of epileptic shock, Preston, thinking about that. Did your leg ever vibrate when there was no pager there? That syndrome where because that thing would go off. John, I worked 8 to 5 at the Community Mental Health Center, and then I worked the crisis team. This is in the 90s. And you'd get off and you just pray.
Yeah.
You could get a call at 6:30. You're trying to have some dinner. You're out for 2.5 hours. You get a call at 10. You get to bed. You lay down for a few minutes. You get a call at 2. And then you're just praying that you get Nope. You get a call at 5. And then you're back at work at 8. Preston, is that trauma ring a bell?
David, as you talk about it, it's almost like, what do you call it? Phantom limb pain, where you get a limb cut off and you can still feel it.
Yeah.
I still have a little, every now and then in the shower, I'll have a little shudder from scary driving events. Speaking of 2 a.m. wake up, driving 30 miles from Buena Vista, Colorado to Leadville, Colorado. And there were icy roads 6 months out of the year. And
Preston,
so
that is so funny that you mentioned that. How many times did you get pulled over in the middle? I bet I got pulled over at least 6 times driving too fast at 2 a.m. Never once got a ticket. I always said, I'm headed to Redmond Emergency Department. I know I'll be more careful, officer, but I'm going to do a mental health assessment. I didn't try to talk my way out. I just told them what was going on. They always let me go, always said, you need to be careful. Did that happen to you, Preston?
Absolutely. Total road warrior.
Preston, I worked for the crisis team. This is again in the 90s. And my boss was, he was the regional director for the Community Mental Health Center, but he led the crisis team, the mobile crisis team. And one of his things he was most proud of is he had never left his home for mobile crisis. And I'm like, that's not mobile crisis if you call them on the phone.
Right. Well, it's a great point. And, I'll put in a plug for this. As you think about sort of mobile crisis is, how can you create context so that your people can say yes? And it's easy and have the support and the safety and being forward leaning in terms of providing services. And I think it gets into, now we're in this place as we think about mobile crisis, sort of what's the right scenario for it. And for me, I had an integrated hotline in mobile crisis in Dallas. We just had to, to get it. And, I think we'll get there in terms of sort of clarity. If you think about inclusion, exclusion criteria, I just adopted and got the team to adopt the mindset of, if it rings, we roll.
Rings, we roll, but you were integrated, Preston. So the fact that you were integrated contributed to your team had already decided according to a set of protocol, and the mobile team worked within that context.
absolutely. And right now, when they're separate, the current state is those are negotiated referrals.
Okay, we're going to come
And-
back to that. We're going to come back to So, John, let's go to our next segment, which we call the good news. And normally it's more timely than this one, but this is such good news, even though, oh my gosh, Preston, it might have occurred in 23 now that I think about it, when you and Matthew Goldman did the survey with SAMHSA of mobile crisis.
Mhm. Yep.
So, John, I'm going to put the screenshot I took at National Council last year in St. Louis, when I just think there's so much that was great in that presentation, but this one, Preston, is just home run. John, it reminds me of the decades that you and I worked with Richard McKeon, and primarily Matty Gould and people like John Califat and Brian Mashar were leading a research agenda, an outcomes and data agenda around improving crisis services, primarily the call line at that point. And to see Matthew and Preston heading down the same path is pretty cool. John, your reflection on this survey that they did of a nationwide look at mobile.
Well, Preston knows this was something I was very much involved with. When I was with Vibrant, David, this was a priority. Because we wanted it to address the continuum of care, and I knew about Preston and Matt wanting to do this, so we provided the funding for them to do it. So I couldn't wait for these findings to come out. We worked with them on the actual the dissemination of it to the teams as well as the survey itself. And I can't say any of this surprised me, Preston. I don't know. It basically confirmed a lot of suspicions for me. I don't know about you.
It did. And let me just say this, John, I'm going to be eternally grateful for you. If it hadn't have been for you, this thing would not have gotten over the finish line. It's, Matt and I, we labored away for a while, but it was very cool to get engaged with you. I knew of you from afar, and, you just, you blew away all my positive preconceived notions, and I'm super grateful for the support and for your involvement.
Well, I really appreciate it, Preston. And to me, it was like finding my people. When I met you and Matt, it's like, oh, these are my people. We've been working on doing stuff for helplines. We moved that way across the goal line, and here we are still at the 1 yard line for mobile crisis. So you and Matt, and trying to see what can we do to get us to the goal line for mobile crisis.
Yeah, along with you, not terribly surprised, but I think the essence for me is if you think about sort of implementation science or implementation just processes, doing evidence-based implementation is, we've got this standard, we've got this thing that's objective, and we've got a unique local context, and it's how can we inject something that adheres to a standard but addresses the local intimacies. I think that really is just key in terms of thinking about it. And I think what's happened is mobile crisis teams have really sort of leaned into unique context and necessarily hadn't held on to standards because there haven't been standards that have been published. And, a lot of people have been, making the rules up as they go along.
Well, and that's the reason this work is so important. Preston, I was thinking about this as we went through this. We missed you in Amsterdam last summer for the Crisis Now 3 Summit.
I know.
So one of the things we did was we had a set of trivia questions, and a couple came directly from your work. So we were inspired by your dashboard to ask, how often is fire dispatched by 911 versus some other means? I absolutely would have said that answer was 100%. It's not, but it's very, very high, Preston, is that you get the fire department by calling 911 the vast majority of the time. Whereas your survey found that mobile crisis is dispatched by 988 only about a third of the time. So really just amazing stuff that sets the groundwork for us moving into this next era of you in the Travis podcast, you called mobile crisis the fourth first responder.
Yep. I hope it is. I want it to be.
So I think the question John and I wanted to ask you about all this is tell us 2 or 3 of what you thought were the biggest findings out of this survey.
Well, I think again, not surprising. I think the lack of digital and functional operational connectivity with the rest of the crisis system. If you think about mobile crisis there's even a lot of hotlines that don't even have a formal memorandum of understanding with the mobile crisis teams, not to mention sort of digital integration. So I think that notion of it's sort of out there and not integrated. And I think that peeves a lot of people off at times because they just want to do if I call, we want you to respond, as opposed to, I've got this whole, almost like a back in the day insurance company, sort of a pre-op interview to get to that really strong. And then the other one was, and, we talked about it and you've responded to this, is, scale matters. And the number of mobile crisis teams that don't have scale, either because they're not part of a larger organization, sort of integrated with the hotline or integrated with a crisis receiving facilities, and sort of getting over that sort of minimum threshold of 12, the number of mobile crisis teams that had fewer than 12 total staff, executives, sort of supervisors and people. It's kind of like, what is it? I guess, David, it's a kind of a back to the future in terms of people are still kind of on the ragged edge, working their regular shift and then being on call. And, there's very few places that have really done the investment that's necessary to allow mobile crisis to stand on its feet, like we would with 911, like we would with law enforcement, fire, EMS, or even, sort of emergency departments. And so I think it's still little and young in that regard.
Yeah. John, I'd like to call an audible here, if we could, and reorder a little bit based upon what Preston's talking about. And to do that, John, I'd like to do some incredibly true tales of behavioral health link. What do you think, John?
Well, I mean, it's happening, and I'm not sure that these are going to be true. So just wait for me to challenge that.
Not true, but incredibly true.
Okay, incredibly. Well, okay, incredible means it's hard to believe. Okay.
Okay. So this is the downtown Atlanta. You can see the Georgia Pacific building up at the top on Peachtree Street. But I love this Jesus Saves sign, a lit up neon sign right on this Bethel Baptist Church right in downtown. Now, at the time I was here 25, 30 years ago, they didn't have the, and I'm blanking on his name, Lewis, Congressman Lewis, mural that was across the street there.
Yeah.
Amazing. But Preston, operated starting in 2002, we took over the 40-year-old Fulton County Crisis Line. That was the first thing that we did as we started up Behavioral Health Link. We had an office that was about 2 blocks from here. And we answered the single point of entry, which was the crisis and accident line for Fulton County, and then Clayton, and then statewide, and et cetera. But when we began on October 2nd of 2002, that Fulton County line had been answered since 1966. But when we began, mobile crisis was operated by a different organization, John. It was operated by FCCSS, the Fulton County Collaborative Crisis Service System. And Kyria Fayez and her team were in a building right next to the Jesus Saves Tower. And I went there once a week to meet with the Central State Hospital, Preston, named the exact same thing. We had multiple Central States, but we had one in Atlanta. We had the Grady Hospital leader and the mobile crisis leader and a number of others that would meet. But we would make a referral to mobile crisis because we had assessed that this is more than we can handle and support over the phone, that more services, more support in person assessment and intervention was needed. So we wanted the fire department to roll. There's a fire. Let's roll. But we faxed the referral to FCCSS.
Yeah,
It's 2 blocks away, but they're in the building on the other side of this church. We'd fax the referral together, and they would have a staff meeting. And they would assess whether or not they were going to go out and do a mobile crisis engagement. And it typically took about 45 minutes for us to find out whether they would or whether they wouldn't, or whether they'd try to handle it over the phone. And oh my God, John, this was 22 years ago, and that flew all over me from day one. I'm like, we've assessed that they need the mobile thing.
Imagine how the people who phoned in were thinking, what are they going to do?
Let them fly.
Yeah.
Preston, that's not a tall tale. You know that happened.
Yeah.
That's true. That's what unbelievably true.
So that brings us into our trivia question for the day. This is our formal over-under, John. And John, we got to tweak this for 2025 because I've now been using over-under a couple of times. But City Skylines is a video game where you build communities.
Yeah.
I've never seen it before, but I came across it because I was looking for something on ambulance coverage. And on Reddit, I found the thread where people building these communities were finding they couldn't get the outcomes they wanted because they didn't have adequate ambulance coverage in the video game. And this person was like, how do I get enough coverage to make sure I can respond in 8 to 10 minutes? Otherwise, the health outcomes plummet, and then that has an impact on downstream. And but the bottom line is, when we started this work in the 60s and 70s, 911 would get answered, Preston, and ambulances were unique to the community. What do I mean by that? Some communities leveraged the coroner's vans, hearses, police cars. Some had something around an ambulance. Some didn't have anything at all. It was all unique and customary. Today, we have the supports for an 8 to 10 minute response in most urban areas, a 14 to 15 minute response in rural areas. John Draper, how many ambulances are active in the U.S. today? That's the over-under. And Preston, he's going to pick a number, and you're going to tell us whether he's high or low.
The actual number, David? Give me that
number. So when that first 911 call was answered in 68, John, my guess is there were, handful of ambulances nationwide.
Yeah.
How many are there today, John?
Wow. Oh, this is going to be
look, in 2024, you were really good at these. You just problem solved them through.
Well, but there's I don't have any data to work with. So it is a wild guess. So
do you want me to give you there are some 30 million EMS responses annually.
30 million EMS responses. Oh, that's helpful. That is helpful. Okay. And let's assume that there are, for each, of course, that's 30 million for the entire year.
Yeah, for the year.
All right. Oh God. That's all right. I'm gonna say there.
Preston, if you feel like you have a guess, Preston, normally I put the pressure on John and you pick the over under. But if you have a number, we'll let John do the over under.
I'm gonna say 10,000.
10,000 is the number, Preston. Higher or lower?
Oh, way higher than that.
Yeah, what do you think, Preston?
I'm thinking more like 250, 250,000.
So this is the best I can tell, and it's not exactly clean, but the National EMS Assessment, similar to what you did for mobile crisis, but the last time I can find it is 2020, and they did a survey with almost 90,000 EMS vehicles, which, John, includes 1,500 helicopters.
Oh, wow. Yeah, I was thinking 100,000 little closer, but
Yeah.
That's funny. I work with the fire departments, and they love them some helicopters. That is faux sure.
So
well,
about
you got to have it.
a good 85,000 vehicles, and that
Okay.
does not include the embedded EMS and fire. There are another at least 20, 30,000. So we've got well over 100,000. So Preston,
Yeah.
your 250 was not way off. I haven't seen a 2024, but we're talking over 100,000 vehicles that are spread throughout the country, and with the design to ensure that we have the capacity for responding to these needs. So Preston, that content was later in the program, but I wanted to do it now because of your focus on scale matters.
Mhm.
And for us to have the response for people in need, we're going to have to invest in these more traditional community-based teams going out to the person.
Absolutely. And, one thing that I see quite a bit is sometimes payers are reticent to allow, sort of the hotline or the receiving facility to also have sort of the mobile crisis. Sometimes payers get worried about having all of their eggs in one basket. But if you think about it, for rural to, get to a place where you're, getting close to urban response times or capacity, it's the average unit cost gets really high unless you're embedded within a larger organization or unless you allow the mobile crisis to get pointed at other things. And I'll just give you a simple example. Sometimes, people, if I fund the mobile crisis, you can't serve jails. You can't go to other places or emergency departments where there's other professionals present. And, there's a penny wise, pound foolish thing that's sometimes going on with payers. And for me, it's like, evaluate them. You got all those encounter records, figure out what people are doing, but, allow, if you've got if it rings, we roll. If you've got a truly a response-based organization like Fire EMS, they're not quibbling. Like if 911 calls, they go. To get to that point, you've got to have the capacity. And going back to the team meeting to process a referral to mobile crisis, that's sort of that notion of that's a dispatch. The reality is, I think we're closer to that than a true sort of digital dispatch through software like yours or through some sort of CAD system where people just get it and they respond. Now, I think the one issue people are talking about safety is, if I got a 2-person mobile crisis team, we can figure out safety considerations in route. When I'm a block away, I might need to make a game time decision that we're going to ask grandma to come out and we're going to take her to the local Starbucks and have a chat in a safe place away from her grandson right now to begin the process. And I think that if you think about it, I think the biggest opportunity is not only getting big enough from the funding, but helping the mobile crisis teams figure out how to negotiate to the yes, how to get a quick yes in terms of the response. But I think, when we're in that place right now where we're kind of going, well, is this right? And, because sometimes the acuity can get so high, the mobile crisis team just goes out and witnesses a bad train wreck going down where they're doing, involuntary holds as the majority of their business. And I don't think I think it needs to be a little further upstream in terms of there's an opportunity to play the three bears, sort of too hot, too cold, just right. And I think sometimes the just right for mobile crisis has been too small. I think it needs to expand in both directions.
Yeah, well, Preston, I think you really do emphasize the importance of flexibility, thoughtfulness. It is really person-centered. That if we're not thinking, from the distance, here's what must be done for every mobile crisis call. And I imagine that you run into a lot of rigid, limited thinking in the people that you're working with here and there. They, in consultation, they have an idea of what mobile crisis or crisis services or their system should be, but they look to you because they don't know, and you must run into quite a number of myths and misunderstandings from people that you consult with. What would you say are some of the more common myths or misunderstandings or thought errors that people might have just because of naivete that you like to say, hey, let's think about this?
It's around safety. And I think that, and I know you guys have done some cool work in terms of, with Jack Roselle looking at sort of violence and violence risk assessment and that sort of stuff. But I'll just give you, I'll do a, y'all may recall some of the foundational research. Actually, prior executive director for AAS, Lanny Berman, did some initial studies looking at what percentage of mental health professionals, psychologists and master's level folks had a formal course in suicide care. 3% in 99. That really hadn't changed much. It's worse for violence in the behavioral health disciplines. And so I think people are filling a void because they don't understand the science of violence and they don't understand how to ask good questions. I'll just give you another thing about violence is we don't have anything, and I'm not saying that Columbia is the end all be all, but it's a thing. It's an important thing, right? It's a source of evidence. We don't have something analogous on the violence front. And, many people don't understand, what is agitation? How do you assess agitation? How is it that agitation can be a precursor to violence? You got agitation, pre-violence, and then violence. And how do you go about assessing that? And even if things are a little sketchy, how can we figure out a way to engage the people that need to be engaged in a way that's safe for all? The quick no and all the myths. And I'll tell you, mental health professionals are as bad as everybody. It's kind of like, when NAMI's out, everybody's wanting to say, hey, there's this myth. People with, clinically significant mental health problem, behavioral health problems are more apt to be victims than perpetrators of violence, except for a handful of folks. But that gets thrown out the window when you're up close and personal and people are highly aroused and agitated and you don't know how to assess for those dimensions. And then the other one is that, there's a lot of ignorance about firearms. And, how do you assess for that? And there's some mobile crisis teams out there that will not respond if there's a firearm in the home. And speaking of Texas, you wouldn't provide mobile crisis. In Texas. I'll pause there. But those are the two, that's the core myth.
Big one, Preston. And just to note about, assessment tools are one thing, but I've noticed, I know this about clinical care, clinicians are much less apt to assess for something they don't know what to do with. And if we do a better job of assessing, we sure as hell got to do a better job of teaching people how to deal with circumstances where violence might be occurring. And we can do that. It's a lot of it is very similar to suicide prevention care.
Absolutely.
So once you get a sense of that, then assessing for it is not going to be so scary. But it's certainly, to your point, is crucial when you get out in the field.
Yeah. Preston, and you bumped all up against this in your response to this question, but on Travis's podcast, you referenced the language of imminent risk and a preference for a focus on immediate danger. You want to add anything to that?
I think, it just gets to the issue. And it's really been influenced by my work with 911 across the country in terms of sort of thinking about it is like, is the person threatened to do something? Have they already done something? So it creates at least a tangible focus. And my work with sort of 911 workers is, do you think that the person is apt to do something? And, Margie can talk about, there's some real cool recent research coming out, just sort of asking about self-perception and then asking about observations. And, sometimes hotlines and 911 PSAPs, they get kind of jacked up around sort of third parties. But for me, it's kind of like, I served kids for a long time. I'm talking to third parties all the time. If I want to know what's going on with the kid, I'll talk to them, but I'm also going to talk to the parent or the parent equivalent. And if you think about sort of hotline or mobile crisis work, we can discern a lot from another person. And, and kind of, how do you figure out is someone telling you the gospel? And if so, how can you ask a third party about suicide risk considerations, about violence risk considerations, because they know. And so I think that there's a lot that sort of needs to be turned on its head. And I think the other one is, how can we foster the use of imagination and creativity in terms of evaluating these things, as opposed to the rigid is like, well, third party, I don't know, if I can't talk to them, I can't figure it out. It's kind of like, hey, they're agitated. They, back in the day, there was a DV event, blah, blah, blah. We can't respond.
Do whatever we can do. What can we do? Not what we can't do is the first one.
Yes.
Yeah.
Yes,
Love
absolutely.
it. Love it. Preston, one other topic that came up, we were talking about scale earlier. You referenced the SAMHSA investment in CCBHC and some of the challenges and opportunities there. You want to talk a little bit about your perspective on, again, it comes to how do we invest in these services so that they can do what they're designed to do and do them at the level that they're needed based upon the, call it network sufficiency, or the metrics we're looking for in terms of responsiveness.
It is. And, I don't necessarily want to throw shade, and I certainly get it. And I've, worked with SAMHSA and worked with CCBHCs and worked with a lot of them around this. And, I'll just use this as an example. It's pretty clear to me that when on the CCBHC grants on the expansion, and it's particular for mobile crisis, I don't think SAMHSA really liked budgets coming in sort of exceeding that $1 million level, which means that nobody had a big enough response. So when I look at it, you got a sort of a director and maybe 6 people, kind of a ragtag crew on those CCBHCs. Well, you know what they're doing? They're not responding solo unless they're a known entity. So they're going out with law enforcement, which is a co-responder, or they're going to schools, or jails. And it's kind of back to the future, David. It's kind of like back on it you and I were talking about with a pager. It's kind of like, okay, well, I did that way back in the day. And so I think that, and I was, very, trying to be very nice about it in terms of sort of, pushing a number of folks, but I felt like, I don't know that I would have preferred to have seen fewer awardees and allow people to get big enough to do it for real, as opposed to spreading out so that, each state, and I know that I couldn't imagine on that side, it was a really tough thing. But I think kind of the issue is with some of that, if you're not going to respond solo, then you got to figure out, you got to be able to do some 5th grade math. And it's not just sort of the people. You got to have a director level person. You got to have supervisors. You got to have, clinical staff and peers and other paraprofessionals. You got to have some quality capacity. And if you're not part of a larger organization, that starts bumping up against 20 FTEs really very quick. And that gets expensive, and then people get the yips about it. And so, I'm staying in there, trying to be focused and not humiliate people. But by the same token, it's, scale matters. And, if you want people to do it, you gotta be flexible on some of the rules, and you gotta pay those people.
Otherwise, you're back to Jesus Saves and the referrals to the, let's do 45 minutes to take a look at.
Oh my God, I'm never going to forget the Jesus Saves and the round table processing the mobile crisis referral.
Yeah. So, John, and Karen's just given us a prompt here about closing out our, we're in season 2. We're going to be making up some new stuff as we go along. I think, Preston, what's your call to action? What do you want to see in 2025, or build off something you want people to take away from this episode?
Well, I'll say this. I think I think there's a lot of people that are feeling demoralized, and I think that there's reason for optimism in terms of there's already been modest return on investment that's been demonstrated with crisis care. And I think for those of us in that game, we need to keep leaning into value. And value is bipartisan. And there's value to the public sector safety net. There's value to 911. There's value to law enforcement. There's value to fire EMS. There's value to emergency departments and jails. And I think that, if you got your pitch right, it's an easy sell across all levels of politicians.
Lean into value, Dr. John Draper. Look, lean into experience, lean into pragmatism. I love everything we heard from you today, Preston, your long-term leadership in this space, your focus on the practical, your focus on a vision, and the mechanics of how business works and making this successful. Terrific stuff, John.
It sure has been, and really appreciate that, Preston. And that notion of value, I want to talk a little bit about in this Plain Truth segment, because crisis hotlines were really able to demonstrate their value. And that's how 988 happened, is because there was evidence showing it was effective. But
well, John, look, if this is the way we kick off 2025, this is good stuff. But Bill Maher's got new rules. The 988 podcast has Plain Truth. Dr. John Draper, bring us home.
Well, happy to do it. 1989 wasn't just a Taylor Swift album or her birth year. It was also the first year that I completed my postdoc at Manhattan State Psychiatric Hospital, and I joined a Brooklyn mobile crisis team then. We visited people with severe psychiatric symptoms all over the borough who couldn't seek care on their own, and referrals usually came from concerned friends or family. Now, I love that work and spent 7 years there. But nearly 30 years later, after focusing on helplines, it's been fascinating to see what's changed in mobile crisis and what hasn't. Now, from a technology standpoint, things have changed. Helplines have been using software for years and extended access to crisis services through text and online chat services. And mobile crisis is catching up with helplines and using technologies such as GPS-enabled dispatch software. We're not using pagers anymore, guys. Mobile apps for in-field assessments, and telehealth for medical consultations or evaluations in safe settings like jails or schools. Now, there's been another shift. In my day, teams weren't often required to operate 24/7, unlike crisis helplines. Many mobile teams now do operate 24/7 with response time targets, often 60 minutes, mirroring a speed-to-answer mandate for crisis lines. But that's not to say that they don't have challenges staffing 24/7. You heard Preston talk about this. That scale, they can say they're doing this, but they just don't have the staff to really do it in a consistent, capable way. But peer support, now that wasn't common in the 90s. Now we did have this in New York City, started in 1994, we were required to do it, but the roles of peers weren't well defined. And today, only about 30 to 40% of teams have peer specialists. And this is all from Preston's survey, by the way, and we're still figuring out the best approach for applying the unique skills of peers in mobile crisis services. So what else hasn't changed? As I mentioned, there's still a lack of evidence-based practices for mobile crisis. We have evidence-driven national care standards and crisis helplines, thanks to continuous federal-funded crisis hotline evaluations since 2001. As for mobile crisis service, research on what works is scarce. Most of it's about 20 to 40 years old. It's most of the same information I had 30 years ago. The primary metric remains reducing unnecessary hospitalizations, yet we don't have solid data on which practices, clinical practices, work to keep people out of hospitals. Our Brooklyn team was pretty darn good. In fact, we were the best in the city at keeping people out of the hospitals, probably because we could prescribe meds and we made repeated visits until people were connected to care. Still, sometimes hospitalization was unavoidable, especially when severe thought disorders required long-term support. When the people we were seeing were still going in and out of hospitals, no matter how we tried to engage them in care, well, we referred them to the assertive community treatment programs, the ACT teams, for longer-term in-home stabilization. New York was a leader in promoting ACT programs, and research showed that for persons frequently hospitalized for serious mental illness, ACT teams are highly effective in reducing hospitalizations and also increasing their clients' quality of life and their housing stability. However, when our team referred people to ACT teams, There were long waits. It was like winning the lotto to get in. Today's surveys indicate there's still a severe shortage of ACT teams across states, and we're still a long way from getting where we need to get with mobile crisis team availability everywhere. So we are in our toddlerhood, guys. We know that with 988. We got a long way to go. And while crisis helplines have advanced with federal funding and strong leadership, we absolutely need similar progress for mobile crisis and other crisis services. So with more funding, research, and collaboration, we can strengthen the entire care continuum. And David and Preston, I look forward to continuing this work with all of you. We got a lot of work ahead. David?
I know some plain truth, and I love the combination of the practical challenge and history, but the optimism and progress and the hope for the future that we heard so solidly in Preston's discussion today as well. Preston, Full Tilt Strategies, you're doing consulting and support. People in health plans and counties and states, federal government can outreach you to help lift up their work as they move this forward and find that balance of how we can create a system that's more effective. Next week, we're going to be with retired police department in Shelby County, Memphis, Tennessee. Major Sam Cochran is such a champion with CIT. But look, we've got an amazing year ahead. And we're going to keep looking at how we can build on the success that we found in this last couple of years of 988 and start taking that vision forward. For those who have more urgent needs, a call, text, or chat for 988 can ultimately lead sometimes to disappointment in that what happened after that call didn't feel like the support that was needed. And mobile teams are one of the most accessible ways to start moving this whole thing forward, Preston. That can happen this year. And there are communities around the country who are focused on bringing that forward. So we stand ready on this podcast to keep bringing attention to that. Preston, we know you're going to keep doing that work. Join us next time. And until then, stay safe. And we'll see you on the 988 podcast. Thank you.
Y'all take care.